בחודש מאי מצוין ברחבי העולם חודש המודעות הבינלאומי לסרטן העור מלנומה. לפי נתוני העמותה הישראלית למלנומה אובחנו בשנת 2013 1,634 חולים חדשים עם מלנומה ממאירה של העור. בימים אלה מתארח בישראל דוקטור ג'ד וולצ'ק. דוקטור וולצ'ק מתמחה במחקרו בסרטן עור מסוג מלנומה גרורתית. הוא מכהן כיושב ראש רשת הניסויים הקליניים של המכון לחקר הסרטן במרכז הסרטן ממוריאל סלואן קיטרינג בניו יורק. לזכותו של דוקטור וולצ'ק ייזקף הטיפול מציל חיים במסגרת מחקר קליני במלנומה גרורתית, בו היה רופאה אישי של דוקטור חדווה גונן, מנכ"לית העמותה למלנומה בישראל, ביוכימאית מהטכניון ויד ימינו של חתן פרס נובל לכימיה פרופסור צ'חנובר, הנמצאת עמנו גם כן. שלום דוקטור וולצ'וק ותודה על הראיון. עד כמה אנו קרובים לפיתוח תרופה לסרטן העור בפרט ולסרטן בכלל?
So thank you for having me. Very fortunately, there have been numerous new medicines approved to treat melanoma just in the past 5 years. And these have all been approved based upon extension of patient survival, which is of course very important, a very meaningful endpoint. So we now have numerous medicines that benefit some people by blocking pathways that drive the melanoma cells to grow. These are called targeted therapies, and we also have immunotherapies, which use the body's own immune system as a way to treat cancer. They don't benefit all patients, but some of these benefit the majority of melanoma patients. I think what we're now recognizing is there is not going to be just one treatment for all cancers. We are treating hundreds, if not thousands, of different diseases because of differences in genetics from person to person in terms of their tumor. So I think we are learning more every day, and we are going to develop treatments that may be specific to each person as time goes on.
כיצד ניתן ליצור מניפולציות ולהפעיל את מערכת החיסון הטבעית שלנו כדי שתילחם בגידולים סרטניים?
So we've learned very much in the past few years about what turns the immune system on and what turns it off. And we have some very effective medicines that do that, have extended survival in melanoma and also in other cancers, lung cancer, kidney cancer, head and neck cancer, now some kinds of lymphomas as well. So as we learn more about the individual ways in which the immune system is regulated, we hope to develop even more medicines. We also have some ways of using the patient's own immune cells that are grown outside the body and then given back. This is called T-cell therapy, and it is being done in various hospitals, including hospitals here in Israel. And this is effective for some patients who don't benefit from other kinds of immune therapy.
הטיפול בסרטן בכלל ובמלנומה בפרט באמצעות טיפול ממוקד מציג השפעה מהירה וטובה על תאי הסרטן, אך היא זמנית. אם כך, מדוע לא להתחיל ראשית בטיפול אימונותרפי?
So this is very important that most of the time targeted therapies have a very significant effect, causing the response in most people who have the appropriate mutation in the tumor, but that those responses usually only last about a year. It's important to recognize that that is a median. So that means that some people have responses that last shorter than a year, and there are some people who have responses that last longer than a year. In general, responses to immunotherapy do last longer, and that is why in most people who have melanoma, for example, who are not acutely symptomatic, acutely unwell, we do try to start with immunotherapy.
האם ניתן לשלב טיפול אימונותרפי עם טיפול גנטי או כל תפיסה טיפולית אחרת?
Right now, we are investigating combinations of different therapies with immunotherapy in different clinical trials. I think it's too early to know how these different combinations are going to compare with each other.
הטיפול שעומד היום על אחוזי ההצלחה הטובים ביותר הוא קומבינציה של שני טיפולים אימונותרפיים, עם כ-60% מגיבים לטיפול. מה מיוחד בטיפול הזה? מה הפרוגנוזה לחולים? והאם יש קצה של פתרון לאלה שאינם מגיבים?
This is an excellent question. There is a combination of two immunotherapy medicines that produces a response, a significant reduction in the amount of tumor in about 60% of patients. In general, most of these responses are durable, lasting several years at least. I would say 80% of these responses are durable. What the prognosis is for these patients, we hope that it continues to be durable, but we don't know yet because we have only had access to this treatment just for a few years. For patients who don't respond, if they have a mutation in the tumor that is appropriate for a targeted therapy, we would offer targeted therapy. We might offer them adoptive T-cell therapy, which is what I referred to in terms of taking the patient's immune cells and growing them outside the body. We also sometimes treat patients with standard chemotherapy, and sometimes they can have dramatic responses right after immunotherapy. We also, of course, always consider clinical trials of new medicines so that patients will have access to the most modern interventions possible.
האם לדעתך לרוח לחימה ואופטימיות יש יכולת להשפיע באופן טוב יותר על התגובה של מערכת החיסון על הטיפול?
I don't know for sure if having a high degree of optimism scientifically affects someone's immune system with this therapy, but I do know that the better the attitude the patient has, the more satisfied they will be with the treatment as they go along, and perhaps the better they'll be able to cope with any side effects if they remain positive that the goal is to control the disease with this treatment.
מאחר וחודש מאי הוא חודש המודעות לסרטן העור, האם אתה יכול לתת לנו טיפים כיצד ניתן למנוע את סרטן העור ולהגן על העור שלנו מפני השמש?
So the only controllable risk factor that we know of for melanoma is using appropriate sun protection. It's true that not all melanomas are related to sun exposure, but many are. And so that's why in particularly sunny places like Israel, especially at this time of the year, it's important to take protection, wear hats, wear sunscreen, stay out of the sun at the highest ultraviolet hours of the day, in the middle of the day. Not necessarily to live in a cave, but rather to just use common sense with sun exposure, and importantly also to make sure that people are getting good skin examinations so that any changes in their skin can be detected early.
ושאלה לסיכום, האם אתה יכול לסכם את התפיסות הטיפוליות במלנומה גרורתית בשנת 2016 ובשנים שיבואו?
So treatment of melanoma in 2016 is so much better than it was just 5 years ago. We now have many medicines that all enhance survival. We have combinations of immunotherapies which are producing responses in 60% of patients. We have targeted therapies which in appropriately selected patients produce responses in similar high numbers of patients. And I think what the future is going to be about is further combinations, new immunotherapies that are being tested, adoptive T-cell therapies being given along with the currently available immunotherapies, and combining targeted therapies with immunotherapies. We are at a very exciting time in the development of new treatments for melanoma, and it is indeed a time of great hope.
תודה רבה לך דוקטור וולצ'וק על הרעיון.
Thank you for having me.
בנימה אופטימית ומעצימה זו, אני מודה לך דוקטור וולצ'וק על הרעיון ומאחלת לכולנו בריאות טובה.